This lecture will cover dermatology for the pediatrics board exam. We'll start with birthmarks. The capillary malformations or port wine stains are birthmarks that darken and grow over time. If the eyelid is involved with this birthmark, they should have an eye exam to rule out glaucoma. And if any patients with port wine stain or capillary malformations have neurological symptoms, you should consider an MRI. You should also consider an MRI if they have bone or soft tissue overgrowth. We think about the syndrome Klippel-Trenaunay syndrome, which features port wine stains, an AV fistula that causes hemihypertrophy, unilateral limb overgrowth, and congestive heart failure. For port wine stains or capillary malformations, these can be treated with laser therapy by dermatology. Another birthmark, the nevus simplex. These are midline vascular patches that typically fade with time by 2 years of age. These also blanch with pressure. So the important contrasting point is that nevus simplexes fade with time and port wine stains or capillary malformations will darken with time. Sturge-Weber syndrome features a facial port wine stain in V1 that causes glaucoma, leptomeningeal angiomatosis and seizures, and soft tissue overgrowth. Finally, the nevus sebaceous birthmark is a yellow or pink hairless plaque. These patients have a small risk for basal cell carcinoma. Nevus sebaceous can be excised during puberty. Nevus sebaceous are also associated with Schimel-Penning syndrome that causes neurologic defects. We'll talk about hemangiomas. These are dangerous during the proliferation phase, but otherwise benign. In the first month, they typically will show rapid growth of the superficial part. This growth is typically complete by 4 to 6 months, plateaus after 1 year, involutes by age 4, and disappears by age 10. Patients with involution and disappearance may have residual erythema or scar at that location. If a patient has a facial hemangioma that's greater than 5 centimeters, they need the FACES workup. FACES is posterior fossa or Dandy-Walker malformation, hemangioma, arterial cerebrovascular anomaly or strokes, cardiac anomalies, especially coarctation, eye anomalies like microphthalmia and strabismus, and sternal defects. If someone has a lumbar hemangioma, they need a workup for spinal dysraphism, and if someone has greater than 5 cutaneous hemangiomas, you should perform an abdominal ultrasound to rule out visceral involvement. Patients with large or multiple hemangiomas can have high output congestive heart failure. High-risk lesions should be referred to dermatology, ideally in the first 1 to 3 months when treatment is most optimal. We would treat them with propranolol for 6 months. Some patients can just do topical timolol if they're small and superficial, and some patients just need observation for benign lesions. Second line for serious lesions is systemic steroids, laser therapy, and surgery. Kasabach-Merritt syndrome features large congenital vascular tumors that are not hemangiomas, and Kasabach-Merritt patients will have a consumptive coagulopathy associated with thrombocytopenia in infants. A 4-month-old female infant comes to your office with this growing lesion. Her mother reports it was not present at birth, but it was noticeable at 2 weeks of age and is growing, more raised, and more red. How would you manage this patient? Start oral prednisone. Refer to pediatric dermatology and ophthalmology. Reassure the parents this lesion will eventually involute. Continue to monitor the growth monthly, or start topical timolol. The correct answer is to refer to pediatric dermatology and ophthalmology. We'll talk about newborn rashes next. Transient neonatal pustular melanosis looks like superficial pustules that don't have erythema. These patients can have scale and hyperpigmentation that persists for months. TNPM is present at birth, favors the forehead and neck, and is more common in Black children. Inside the pustules, you'll see neutrophils or PMNs. If you find bacteria in the pustules, that would suggest an infection. Erythema toxicum looks like flea bites, and inside those pustules you'll see eosinophils. Dermal melanocytosis is usually a lumbosacral lesion that fades in 2 to 3 years, and malaria rubra or heat rash is caused by an obstruction of sweat glands that cause superficial vesicles that are easily ruptured. Neonatal acne is considered benign. You'd know it was a neonatal acne and not infantile acne because there's no comedones and it resolves by 4 months. Infantile acne wouldn't necessarily be resolved by 4 months. It usually takes up to a year, and these patients with infantile acne can have comedones. Infantile acne is from androgenic stimulation. In patients who are older than a year, still with persistent acne, you would worry about CAH or other adrenal hormone problems, and so you should evaluate patients for precocious puberty with acne before age 8. Livedo reticularis is the normal mottling rash that babies have. It can also be described as a lacy rash. Livedo reticularis resolves by 1 month. The differential for diaper dermatitis is quite broad. Irritant contact dermatitis spares the folds, and you would treat this with barrier cream and hydrocortisone. Candidiasis favors the folds and has satellite pustules. To help clue you into this fungal etiology, you would treat with nystatin, clotrimazole, or ketoconazole. Seborrheic dermatitis also favors the folds, and patients may have scalp involvement. You treat seborrheic dermatitis with ketoconazole and hydrocortisone. Bullous impetigo looks like flaccid bullae and has a positive Gram stain. Perianal strep looks like a bright red, well-demarcated erythema. Psoriasis will feature plaques and scale. Allergic diaper dermatitis will be not responding to typical treatments and may have an associated diaper wipes or diaper change. Acrodermatitis enteropathica from a zinc transporter deficiency will show eroded plaques. Patients with Langerhans histiocytosis will have crusted and eroded papules, and patients with Kawasaki disease will have erythema and desquamation. A full-term healthy infant presents for a well baby exam. You notice bluish-gray patches along the infant's buttocks, lower back, and shoulders. No additional birthmarks are seen. You make the diagnosis of cafe au lait spots, congenital melanocytic nevi, nevus of Oda, dermal melanocytosis, phacomatosis pigmentovascularis. The correct answer is dermal melanocytosis. Next, we'll talk about eczema or atopic dermatitis. These patients will have pruritus, a typical morphology and distribution, and a chronic history. They may have a personal or family history of atopy. Atopic dermatitis typically spares the diaper folds when it's causing diaper dermatitis. It's also associated with keratosis pilaris, which is an overgrowth of the horny skin. This is benign and no treatment is needed. Eczema is also associated with ichthyosis vulgaris, which is shown to the right, the patient with fine white scales on her legs. Pityriasis alba can cause a white patch to appear and may take months to repigment. These patients should use sunscreen and moisturizers. Patients with eczema can have elevated IgE, itching with sweating, and eye abnormalities like cataracts and keratoconus. These patients with eczema should be treated with the least potent steroid possible. So on the face, we usually use hydrocortisone 2.5%, and then we use triamcinolone 0.1% for the body. We would consider non-steroidal treatments like tacrolimus and pimecrolimus for patients 2 and up, for the face, periocular areas, intertriginous zones, and for refractory disease. For younger patients that meet these criteria, you can use the non-steroidal crisaborole. These are for patients for 3 months and older. Eczema can also cause secondary infections, especially with excoriation. The culprits are typically Staph aureus, Strep pyogenes causing impetigo, HSV, which can cause eczema herpeticum. You'd think about eczema that's not improving with steroids for eczema herpeticum, and these patients need acyclovir. Coxsackie virus can also cause eczema coxsackium, and molluscum can cause a secondary infection with eczema as well. When impetigo flares occur, you should consider a swab and then antibiotics if we're seeing a positive swab or heavy growth of staph on the cultures. These patients sometimes need dilute bleach baths 2 or 3 times a week. Next, we'll talk about allergic contact dermatitis. Treating poison ivy or poison oak is indicated if you're seeing linear bullae in a patient who's been outside. You'd think about using oral steroids for 2 to 3 weeks in sensitive areas or for severe reactions. And if you use it for less than 21 days, the patients can have a rebound. It'll be pruritic, blistering, and it sometimes will spread because of the oils. Allergic contact dermatitis can also be triggered by nickel, preservatives and cosmetics, and neomycin or bacitracin. The differential for hypo or depigmentation includes vitiligo, pityriasis alba, post-inflammatory hypopigmentation, hypopigmented tinea versicolor, and some birthmarks. Some birthmarks that cause hypo or depigmentation include ash leaf spots, nevus annecumous, and nevus depigmentosus. With vitiligo, you'll see depigmented macules without scale. Vitiligo is commonly symmetric but can also be segmental. It can also kebnerize in areas of friction and is associated with halo nevi. With post-inflammatory hypopigmentation, you'll see an inflammatory preceding rash. Hyperpigmentation can be caused by certain birthmarks like melanocytic nevi, freckles, cafe au lait spots, dermomelanocytosis, and mastocytosis. We can also see hyperpigmentation with lichen planus, which will show a linear distribution, and lichen striatus, which will show distribution along the lines of Blaschko. You can also have post-inflammatory hyperpigmentation. Hemochromatosis and incontinentia pigmenti are some syndromes associated with hyperpigmentation as well. With incontinentia pigmenti, we'll see brown streaks along the lines of Blaschko and peg teeth as an association. Heavy metals like silver and some medications like minocycline, chemotherapy medications, and NSAIDs can also cause hyperpigmentation. A 12-year-old boy has a mole on his back. It is asymptomatic and stable in size. You note an 8 mm brown macule. Which of the following features is concerning for melanoma? Symmetry, border, color, diameter, or evolution? The correct answer is diameter because it's greater than the 5 mm threshold that we think about for melanoma. Melanoma is pretty rare in children. We think about it more in adolescence, and we use the asymmetry, border, color, diameter, and evolution to help characterize the risk of a nevus being melanotic. The diameter threshold, again, is greater than 5 mm. Congenital melanoma can occur from maternal metastases in a newborn. And then for pediatric melanoma, any bleeding or bumps and any diameter would be concerning for patients who are younger than adolescent. This picture shows a dermoid cyst in a typical location over the lateral brow. This is a congenital cyst that usually presents in the first year of life. They're like teratomas, so they can have evidence of hair or teeth inside of them. They're slow growing, but they can get infected, so the treatment is excision. Before your excision, for any midline dermoid cysts, they need imaging. We usually take them out to prevent progression or enlargement and the compression effects. To contrast, this picture shows an epidermoid cyst, which is a flesh-colored nodule, often with a black dot in the center. These are benign, often present on pressure sites like the buttocks and the back, and are seen in children 1 month and older. This slide shows some variants of mastocytosis. On the right, you can see a solitary mastocytoma and then some pictures of urticaria pigmentosa. With mastocytosis and urticaria pigmentosa, you'll see brown hyperpigmented macules that urticate and sometimes blister. The Darrier sign is when you scratch these lesions and they start forming a hive. Mastocytosis is associated with flushing and diarrhea, and you might check a CBC and tryptase to look for signs of systemic mastocytosis. This slide shows ichthyosis. There's different types of ichthyosis. We talked about ichthyosis vulgaris, which is the most common form and associated with eczema. Ichthyosis vulgaris is autosomal dominant and shows scaling on the legs and hyperlinear palms. With all of the types of ichthyosis, you'll see mild to severe sort of spectrum depending on the type, and fish-like scales as the buzzword. Congenital ichthyosis, this is autosomal recessive. It's also called lamellar ichthyosis, shows large plate-like scales and a collodion membrane. Harlequin ichthyosis shows an armor-like and horny-skinned newborn with restricted movement. The patients with harlequin ichthyosis have a poor prognosis. X-linked ichthyosis, to contrast with congenital autosomal recessive ichthyosis, X-linked spares the flexural areas and only affects boys. For all of the different types of ichthyosis, they may need a regimen including emollients, retinoids, ammonium lactate, alpha hydroxy acid agents, and then treating the pruritus and any secondary infections that occur. These pictures show psoriasis, which is showing the well-demarcated erythematous plaques with silvery scale. Psoriasis most commonly affects the knees, elbows, and scalp. A variant called guttate psoriasis shows papules after an infection with strep throat and other URIs. Psoriasis is also associated with nail changes like pitting and thickening, and with psoriatic arthritis. The Auspitz sign of psoriasis shows punctate bleeding when the scales are removed. This picture shows a child with scleroderma. You can see the hard, thickened, and waxy skin with a linear appearance. These patients are treated with topical lubricants, steroids, and immunosuppressives. These pictures show pityriasis rosea. The typical vignette will describe what sounds like a herald patch and then multiple oval pink plaits with a collarette of scale. Sometimes they describe a Christmas tree distribution on the trunk. This can take 4 to 6 weeks to resolve, sometimes up to 3 months, but we just treat it with antihistamines and topical steroids for symptom management because this condition is self-limited. This slide covers acne. We spoke about this before. If a patient presents with acne before age 8, you would think about an endocrine workup, but acne is normal in adolescence. Comedonal acne shows blackheads and whiteheads in the T-zone locations. We treat this with retinoids and benzoyl peroxide predominantly. Inflammatory acne shows erythematous papules and pustules with hyperpigmentation. We treat these with topical benzoyl peroxide, clindamycin, or erythromycin. Nodulocystic acne is more severe. You'll see firm nodules and fluid-filled cysts. Overall, the treatments for acne include retinoids, benzoyl peroxide, antibiotics like doxycycline and minocycline, which show a 50% reduction in 3 months, and some OCPs. Spironolactone, the progestin IUD, and Depo-Provera can all worsen the acne. We use oral antibiotics for large nodulocystic or diffuse acne. We think about oral tetracycline, doxycycline, and erythromycin. Isotretinoin is a very potent oral medication. It's teratogenic as well. So before you start taking this medication, you need 2 negative pregnancy tests, and patients should be recommended to take 2 forms of birth control starting 1 month before initiating isotretinoin and 1 month after that medication is discontinued. They also need monthly pregnancy tests. For the child who's less than 8 years old with acne, think about tuberous sclerosis, CAH, or other precocious puberty causes, and the use of exogenous steroids. You should refer to dermatology for patients with acne that's refractory to your mainstays of care, or if it's systemic or severe. We also think about patients that have fever, arthralgias, leukocytosis, draining lesions, and syndromes. We think about SAPHO that shows synovitis, acne, pustulosis, hyperostosis, and osteitis. There's also a syndrome called PAPA syndrome, PAPA. They'll show sterile pyogenic arthritis, pyoderma gangrenosum, and acne. Pyoderma gangrenosum is a presence of deep blue necrotic and boggy ulcers, and pyoderma gangrenosum also has an association with Crohn's. To contrast with pyoderma gangrenosum, a name alert for ecthyma gangrenosum. This is a Pseudomonas infection in an immunocompromised patient. They're either leukemic or neutropenic or septic, and the lesion looks like a black, necrotic, ulcerative lesion with erythema and edema. We typically see these in immunocompromised infants in the groin and diaper area. This picture shows impetigo, which is caused by staph and strep. Staph impetigo is typically bullous impetigo and is common in the diaper area. Strep impetigo is typically non-bullous and honey-crusted. We treat this with mupirocin. If the infection is extensive, we would treat with oral antibiotics. And then if patients have recurrences of impetigo, then you might consider intranasal mupirocin and MRSA swabs. A 3-week-old infant with a history of neonatal seizures being treated with phenobarbital presents to the ED with a 1-day history of diffusely distributed bright red patches and several superficial bullae. The Nikolsky sign is positive. On further exam, you note the mucous membranes of the mouth, tongue, and conjunctiva are spared. What is the cause of this rash? Staph aureus, Kawasaki, drug hypersensitivity reaction, group A strep, or measles. The correct answer is Staph aureus. This vignette is describing staphylococcal scalded skin syndrome. These patients will have diffuse erythema and superficial bullae, as well as perioral fissures and crusting. It's caused by Staph aureus strains that produce an exfoliative toxin. Children and infants that have immature or poor renal function are particularly susceptible because they can't excrete the toxin quickly. You would culture the skin, eyes, nose, and nasopharynx to confirm MSSA versus MRSA. The blister fluid will be staph negative. The Nikolsky sign featured in the vignette for staphylococcal scalded skin syndrome shows extension of the blister when you apply a tangential pressure. The diagnosis is made with biopsy to rule out deeper involvement that would be indicative of SJS or 10. These patients need inpatient treatment with antibiotics. Cellulitis is most commonly caused by Staph aureus and group A strep. MRSA is possible but less common. Typically, we see a patient with a predisposing skin trauma and then presenting with fever and malaise. You treat them with antibiotics to cover group A strep and Staph aureus for routine and non-facial cellulitis. The concerning complication is necrotizing fasciitis, where a patient has rapid progression, intense pain, bullae, necrosis, and a poor response to antibiotics. These patients need a gram stain, cultures, debridement, antibiotics with broad spectrum and anaerobic coverage, and they also need Clostridium coverage. A 12-year-old boy presents with a pink annular scaly plaque on the shoulder. He has a pet rat. What is the most appropriate treatment? Nystatin cream, triamcinolone cream, mupirocin cream, terbinafine cream, clotrimazole betamethasone cream. The correct answer is terbinafine cream. This patient in the vignette has tinea, and this slide helps to differentiate tinea versus nummular eczema versus granuloma annulare, which basically all make these annular lesions. So for tinea, we see an annular plaque with central clearing and peripheral scale. This is caused by dermatophyte fungi. Foot hygiene reduces recurrences of tinea. Usually for foot tinea, it's going to be trichophyton rubrum. We would use oral terbinafine if there's an animal source or if there's a large surface area. Tinea versicolor is caused by Malassezia fervor. It's showing a scaly when rubbed appearance. We treat versicolor with ketoconazole and selenium. You can also use zinc pyrithione shampoo. The second line treatment is oral itraconazole and fluconazole for versicolor. Tinea capitis is also called black dot alopecia, and it can progress to a carrion, which looks like a spongy lesion. Tinea capitis needs an oral antifungal to penetrate through the hair follicle, so we use griseofulvin. Patients can also use ketoconazole shampoo. Other types of tinea, also called ringworm, is treated with clotrimazole, ketoconazole, terbinafine, and luliconazole. To contrast these annular plaques with central clearing for eczema, the nummular type of eczema doesn't have central clearing. It's just an annular plaque and is itchy. With eczema, you're more likely to see this on the dorsum of the foot, with the exception of juvenile plantar dermatitis. With fungus on the foot, it's more likely to be intertriginous than eczema. With granuloma annular, you'll see asymptomatic dermal papules without scale that forms raised circular plaques on the hands and feet. So the important distinction between granuloma annular and the eczema and tinea is that there's no scale, and then the nummular eczema lacks the central clearing that tinea has. Pitted keratolysis shows with patients that have pitted skin in areas of pressure. So you might see patients that have this on their feet and a strong foot odor. And then pityriasis rosea, we talked about a little bit before. These patients have oval lesions with thick scales, a herald patch, lesions in a Christmas tree pattern, and you treat them with light exposure. A 6-year-old girl presents with an edematous, tender, boggy, alopecic plaque on the scalp with several associated pustules. What is the etiology of this lesion? Inflammatory tinea capitis, Staph aureus, lupus, seborrheic dermatitis, or alopecia areata? The correct answer is inflammatory tinea capitis. This patient has a carrion, which is associated with tinea capitis. We use griseofulvin to treat tinea capitis overall, but a patient with a carrion might need prednisone and sometimes antibiotics. Another type of inflammatory lesion, these pictures show molluscum contagiosum. These papules are described as monomorphic and skin-colored and flat and dome-shaped. They also have central umbilication. These are caused by the pox virus. Sometimes we see these papules in a linear array, and sometimes we see them with eczematous patches. It's also called molluscum dermatitis. These often look inflamed or infected right before they resolve. We treat children with cantharidin. Adults we treat with cryo, curettage, and topical irritants like retinol to destroy it. We also use for refractory cases oral cimetidine as an immune therapy. A 4-year-old girl presents with several months duration of varicose papules on the dorsal fingers. She attends daycare and other children have similar lesions. The most appropriate treatment is liquid nitrogen, cantharidin, salicylic acid, candida antigen injections, or imiquimod cream. The correct answer is salicylic acid. For most young patients with verrucae, we would just recommend observation and watchful waiting. The destructive treatments include salicylic acid 17%, duct tape, cryotherapy, 5-FU topical. This is also called Effudex. But these patients with destructive treatment options have the risk of scarring and dyspigmentation. We think about cimetidine immunotherapy. We think about intralesional candida injections, topical imiquimod, and the HPV vaccine as well to reduce the risk of scarring and prevent recurrences. Condyloma acuminata is a GU verrucae. It's associated with child abuse in patients who are older than 3. The HPV subtypes 6 and 11 are the most common causing ones, and these have a low risk for cancer progression. You treat condyloma acuminata with 5% imiquimod cream, podofloxacin, and surgical or laser therapy. This slide covers some of the nuances related to rashes that are caused by insect bites. With lice, you might see a recurrent rash cycle every 3 weeks because of the gestational cycle of lice. Their eggs take a week to hatch and their bugs take another week to mature. There's a high rate of permethrin resistance, so we should treat patients 2 times a week spread apart with permethrin. We also think about malathion 0.5% for children 2 and older, and benzoyl alcohol 5% for children older than 6 months. Some patients with difficult cases of lice need spinosad or topical ivermectin. A variant of lice with GU lice is called pediculosis pubis. These patients might have blue-gray macules that indicate an infestation. These are called macula cerulae. These patients should shave the affected areas and use the topicals that we talked about. If you get pediculosis pubis on the eyelashes, then you have to use petroleum jelly because those topicals can't go near the eyes. Papular urticaria is a generalized hypersensitivity rash that is incited by insect bites. These rashes can last for weeks to months, and any new bites can reactivate old lesions. So patients might complain about recurrent crops. You treat papular urticaria with medium potency topical corticosteroids, and then for the symptoms of pruritus, you might use anti-itch creams like menthol, camphor, and pramoxine, oral antihistamines, and then for prevention, you think about repellents and checking the pets in the home for insects. With scabies, you usually see rashes in patients' creases and intertriginous zones. The patients will complain of pruritus, and the rash may look like crusting papules that are linear with burrows. You diagnose scabies with mineral oil prep, and you treat the patient and family members with 5% permethrin cream overnight, and then repeat that treatment in a week. You should also wash linens in hot water, and for symptoms, you can treat with topical steroids, moisturizers, and antihistamines. A 7-year-old boy with no significant past medical history presents with a 2-month history of hair loss. On exam, you notice several well-circumscribed, smooth, non-scarring patches of hair loss on the scalp. Which of the following is the most likely diagnosis? Telogen effluvium, anagen effluvium, trichotillomania, androgenic alopecia, or alopecia areata? The correct answer is alopecia areata. With hair loss from alopecia areata, this is autoimmune and doesn't leave a scar. You'll see a rapid appearance of smooth patches, and then sometimes they'll describe black dot and exclamation point hairs. Alopecia areata has an omphasis pattern, which means that it occurs mostly along the parietal and occipital scalp. We use the term alopecia totalis if a patient with alopecia areata has lost hair of their entire scalp, and we use the term alopecia universalis if they also lose body hair. Alopecia areata has an unpredictable course. We treat these patients with high-potency topical steroids, intralesional steroids, minoxidil, and JAK inhibitors for adults. Tinea capitis can also cause hair loss. We typically see lymphadenopathy, erythema, and scaling with this infectious cause. Trichotillomania, you'll see irregular and geometric shaped patches. Trichotillomania is associated with OCD. Telogen effluvium is a hair thinning from shedding after an illness or medication use. There's a neonatal form around 4 months of age where patients might see that they have diffuse thinning and a positive hair pull test where they're pulling the hair as if to make a ponytail and getting more hair out than they would expect. You would check ferritin, CBC, thyroid, and ESR for your suspicion of telogen effluvium to rule out other causes, but mostly they just need reassurance. If telogen effluvium is persisting, then you might consider a scalp biopsy with dermatology. Aplasia cutis congenita is when a patient has a congenital absence of skin in an area. Once that skin grows back, it's likely to leave a bald spot. This is associated with skull defects, spinal dysraphisms. So if you see the hair collar sign indicating that your alopecia might be from aplasia cutis congenita, then you should check an MRI. Neurofibromatosis type 1 is often tested. This is an autosomal dominant disorder. To diagnose neurofibromatosis, you should have at least 6 cafe au lait macules. Patients might also have axillary and inguinal freckling, plexiform neurofibromas. You just need one of these to add to your diagnosis. And they may have cutaneous neurofibromas. You should have 2 or more. Cafe au lait macules tend to enlarge and increase in number into adolescence. You would count a cafe au lait macule as one of the 6 if the patient had one that was 5 or more millimeters for prepubertal children and greater than 15 millimeters for postpubertal children. Patients with neurofibromatosis may also have Lisch nodules in the iris and optic nerve gliomas. It's also associated with pheochromocytoma, renal artery stenosis, and scoliosis. Type 2 neurofibromatosis is less often tested, but associated with acoustic nerve tumors like neuromas and schwannomas, as well as eye tumors and meningiomas. What is most likely to be abnormal in a 1-month-old infant with this skin finding? Liver ultrasound, eye exam, renal ultrasound, echocardiogram, none of the above. The correct answer is echocardiogram. You can see on the right ash leaf spots that are associated with tuberous sclerosis. Tuberous sclerosis is an autosomal dominant disorder. These ash leaf spots are hypomelanotic macules. You will see at least 3 of them, and they should be greater than 5 millimeters. You can see them better with a Woods lamp. Tuberous sclerosis is also associated with facial angiofibromas. They should have at least 3 of them, and fibrous cephalic plaques. These plaques and facial angiofibromas are often misdiagnosed as acne, but with tuberous sclerosis, these lesions spare the forehead. You might also see a shagreen patch, which is a connective tissue nevus. It looks like a papular plaque that's hyperpigmented and rough and thick. Tuberous sclerosis is also associated with confetti skin lesions, periungual fibromas, periventricular cortical tumors that cause infantile spasms, cardiac rhabdomyomas, and renal angiomyolipomas. This slide will cover some of the nutritional deficiencies that can cause skin changes. With zinc deficiency, you'll see a scaly erythematous dermatitis. It can be described as desquamating, erosive, and eczematous, and is typically perioral or perianal. Zinc deficiency is also associated with alopecia and poor taste. Some patients will present with appearance of a zinc deficiency if they have acrodermatitis enteropathica. This is an autosomal recessive disorder where patients have a defect in their zinc transporters, so their nutritional status may be adequate, but you might be clued in by hereditary association. With biotin deficiency, patients will present with rash, alopecia, neurologic signs, and sometimes lactic acidosis. The essential fatty acids are linoleic acid and alpha-linoleic acid. When patients are deficient in these fats, they'll have alopecia, scaly dermatitis, and thrombocytopenia, and they need treatment with IV lipids. A 2-month-old girl has vesicles and varicose papules on the trunk, arms, and legs along the lines of Blaschko. Herpes PCR is negative. Biopsy shows eosinophilic spongiosis. Which of the following extracutaneous findings is most likely? Aortic coarctation, dental anomalies, glaucoma, intellectual disability, or seizures? The correct answer is dental anomalies. This girl has incontinentia pigmenti. This is an X-linked dominant disorder, so only girls will present with it. This is because it being X-linked dominant makes it non-viable in males. There's 4 stages of incontinentia pigmenti, and they all follow the lines of Blaschko. The first phase is inflammatory vesicular. This is followed by a varicose phase, and then patients show a hyperpigmentation phase until about 1 year old. After that, they become atrophic and hypopigmented. Incontinentia pigmenti is associated with nail dystrophy and scarring alopecia, as well as some dental anomalies. They can have absent or peg teeth. It's also associated with retinopathy, strabismus, and infantile spasms or seizures. Patients that are diagnosed with IP should have a dental evaluation by age 2, and then they should also have early and serial eye exams. We might look out later for signs of intellectual disability, and then the neurological sequelae can result in paralysis and seizures, as we mentioned. Ectodermal dysplasia, which is related to incontinentia pigmenti, presents with hypohidrosis or decreased sweating, hyperthermia as a result, sparse hair, delayed dentition, and deformed or peg-shaped teeth. Which of the following clinical findings are characteristic of a patient with ectodermal dysplasia? Macrocephaly, palmar and plantar pits, odontogenic keratosis, multiple epidermoid cysts, lipomas, osteomas, sparse hair, peg teeth, dystrophic nails, decreased sweating, mucocutaneous lentigines, gastrointestinal polyps, adenocarcinoma, ash leaf macules, shea green patch, angiofibromas. The correct answer is sparse hair, peg teeth, dystrophic nails, and decreased sweating. This next slide will give an overview about different kinds of drug rashes. Some common exanthems are caused by penicillins, Bactrim and other sulfa medications, antiepileptics, and allopurinol. We see urticaria and anaphylaxis most commonly with penicillins, cephalosporins, NSAIDs, monoclonal antibody medications, and radiocontrast. There's a diagnosis called AGEP in dermatology, that's acute generalized exanthematous pustulosis, and we see that with beta-lactams. Dress syndrome, we see eosinophilia and a rash associated with antiepileptics, lamotrigine, Bactrim and sulfa medications, and minocycline. Stevens-Johnson syndrome and TEN can be caused by sulfa and Bactrim medications, antiepileptics, lamotrigine, allopurinol, NSAIDs, and we usually see this within 2 months of medication use. We call it SJS if it's less than 10% of the body surface area, and TEN if it's greater than 30%, and we just call it SJS/10 if it's in between. With these syndromes, you'll see bullae, erosions, and hemorrhagic crusting. You'll have a positive Nikolsky sign, which also occurred with staphylococcal scalded skin syndrome. This is when you have separation with pressure. We also might see the Asbo-Hansen sign, where the blister spreads laterally with pressure. And we might also see the target lesion that has a dark, dusky, violaceous center. With SJS and TEN, you usually have at least 2 mucous membranes involved, usually the lips and the eyes. An 8-year-old girl who was treated for a staph infection 3 weeks ago with Bactrim presents with a 4-day history of worsening generalized morbilliform eruption, facial edema, and a fever. She has generalized lymphadenopathy, and labs show elevated eosinophils and transaminase levels. What is the most likely diagnosis? SJS, Kawasaki, Dress syndrome, toxic epidermal necrolysis, or erythema multiforme? The correct answer is Dress syndrome. This slide gives a little bit more detail about Dress syndrome, which we already introduced, but it's a drug eruption associated with eosinophilia and systemic symptoms. Dress syndrome has a 10% mortality rate. It's also called drug-induced hypersensitivity syndrome. We'll see a delayed onset of the rash between 2 and 8 weeks after the drug is initiated, but within that 2-month period. Patients will have fever, enlarged lymph nodes at least 2 sites, involvement of 1 or more internal organs, elevated white blood count, eosinophilia, and low platelets. Dress syndrome can reactivate HHV6, HHV7, Epstein-Barr virus, and cytomegalovirus. It can also cause a delayed hypothyroidism reaction 3 months later. It's important to stop the offending drug if possible for Dress syndrome. We would give topical steroids and antihistamines for pruritus, and then the first-line medication for treating refractory Dress syndrome after you remove the offending drug would be systemic steroids with a gradual taper. We mentioned this before, AGEP. It's important to differentiate Dress syndrome from this, which will demonstrate tiny pustules of acute generalized xanthomatous pustulosis, which is the acronym AGEP. We also should differentiate DRESS from SJS and TEN, which will show more mucosal involvement and bullae, and from MIRM, or mycoplasma-induced rash and mucositis. To reiterate, SJS and TEN is a drug-induced epidermal necrolysis, so you'll see skin sloughing, bullae, and mucosal involvement. Adults have a higher mortality rate from SJS and TEN than pediatric patients from sepsis and organ failure. We treat these with etanercept, cyclosporine, and IVIG, but we can see long-term ocular and cutaneous scarring from this. Mycoplasma-induced rash and mucositis, or MIRM, is shown below. It's also called reactive infectious mucosal eruption and is not only caused by mycoplasma but also adenovirus, COVID, and chlamydia pneumonia. This picture shows erythema multiforme, which is caused by HSV and some other viruses. It's typically in a fixed location and lasts about a week. With urticaria multiforme, we see annular urticaria, but it's not fixed like erythema multiforme. To differentiate, erythema nodosum is a painful, shiny red lesion. It's associated with both types of IBD, OCPs, sulfa drugs, Yersinia, EBV, TB, and fungal infections, as well as sarcoidosis. And then to help contrast the different rashes that are called erythemas, erythema infectiosum is the slapped cheek rash of parvovirus. We would use an IgM parvo titer to confirm our suspicion of this rash, and we would look out in susceptible populations for the aplastic crisis, long-term sequela, and if an in utero infection occurs, we would worry about hydrops fetalis. Langerhans cell histiocytosis is a papular rash with petechiae. This is a type of cancerous lesion, and it looks like eczema, but it has papules. It also mimics eczema in that it likes to live in the skin folds. Langerhans cell histiocytosis is associated with lytic bone lesions, especially of the skull, diabetes insipidus. So you would diagnose these patients with a skin biopsy and treat with steroids and chemotherapy. You're seeing a 4-month-old with failure to thrive who has severe atopic dermatitis not responding to mild or medium potency topical steroids. The hemoglobin is 9.9, white blood count is 4.2, eosinophils are 23, and platelets are 35. What additional testing would you order? Serum IgE, WAS protein level, genetic testing for DOC8, or genetic testing for Ullmann syndrome? The correct answer is the WAS protein level. This patient has Wiskott-Aldrich syndrome. DOC8 is a diagnostic test for hyper IgE syndrome. As a review, hyper IgE syndrome causes cold staph lesions, eczema, and HSV infections and warts. Ullmann syndrome is a type of severe combined immunodeficiency that also has severe eczema. Wiskott-Aldrich syndrome is an X-linked defect on the WASP protein, so it only affects boys. The patients will have eczema, excessive bleeding, and increased infections. You might also see hemorrhagic crusting, bleeding umbilical stumps or circumcisions from the microthrombocytopenia, petechiae, and easy bruising. These patients will have low IgM and IgG levels and a low WASP protein. These patients need moisturizers and other eczema treatments, but they also need stem cell transplants and gene therapy for the underlying issue. A toddler with a history of seizures is noted to have a port wine birthmark in the distribution of his left face and forehead. Which of the following conditions is associated with this patient's underlying disorder? Trichiasis, retinoblastoma, galactosemia, congenital glaucoma, Parinod oculoglandular syndrome. The correct answer is congenital glaucoma. A 5-year-old male presents to the clinic with a history of learning disabilities, a number of light brown spots on her skin, and small round tumors on her irises. The most likely additional physical finding in this patient would be elevated copper levels, elevated iron levels, inguinal freckling, ash leaf spots, or a white forelock of hair? The correct answer is inguinal freckling. A 7-year-old presents to the clinic with a raised, ring-shaped plaque over the dorsum of his hand. It has been there for several months and is not itchy. He's been treated with topical clotrimazole without improvement. On exam, there's an annular plaque comprised of dermal papules and no scale. The most likely diagnosis would be Herald patch epidermolysis rosea, tinea corporis, nummular eczema, contact dermatitis, or granuloma annular. The correct answer is granuloma annular. This is the last question. A 4-year-old presents with increased hair loss coming out on the comb over the last 6 weeks. The mother has not noticed any scaling or dandruff. There were no recent significant illnesses, trauma, or new medications. Physical exam reveals a normal appearing scalp without any scaling, no patches of alopecia, and no obvious hair loss. The most likely diagnosis is tinea capitis, alopecia areata, telogen effluvium, trichotillomania, or traction alopecia. The correct answer is telogen effluvium. And that is the end of the dermatology lecture.